Good morning, everybody. It's a great pleasure to be back with you again. Today we have a very interesting and very important topic to discuss. And the topic relates to early loss of pregnancy, miscarriage. And as you all know, this is something that applies very much to IVF. Miscarriage is defined as the passage of products of conception through the opening of the uterus called the cervix and out through the vagina. It's defined as the loss of a pregnancy prior to the 20th week, before there's viability of the baby. It is very common. In fact, about 20% of all pregnancies will be lost in this way. And most of these losses occur in the very first trimester, and that is 80% of them will occur in the first trimester, which is prior to the 12th week of pregnancy. Now, the overall number of miscarriages that occur in the United States at the moment is about 1 million annually. We define or we classify miscarriages into different groups. First, there's the term threatened miscarriage, which means that there's bleeding coming through the cervix, but the products have not all been passed. The baby may be viable or still alive in the uterus, and such threatened miscarriages can be rescued, often just simply through conservative treatment and through adjunct medical therapy along with it, such as hormonal therapy, when we use progesterone and other hormones to try to relax the uterus. Other miscarriages are defined as inevitable. That's when the cervical canal is already opening, and when you introduce a speculum into the vagina and visualize the opening of the cervix, you'll see that it's already dilating, and oftentimes some products of conception are protruding through the cervical canal. Then there is complete, which means that all the products have been passed. You can diagnose this by doing an ultrasound and confirming that the uterine cavity is empty. And then there is the incomplete one, where partial products of conception that are usually dead remain in the uterus. These tissues, known as necrotic, because that means dead tissue, can form a nidus for infection for the ascent of bacteria that are present in the vagina and ascend through the open cervix into the uterus and grow in this dead or necrotic tissue. The threat is that if it's not quickly removed through a DNC or DNE, DNC is dilatation and curettage, DNE is dilatation and evacuation of the uterus, which can be done through suction or vacuum aspiration and or DNC. But it's not completely removed soon after the incomplete miscarriage occurs. The infection can spread through the lining of the uterus, causing permanent damage, not always, but often permanent damage, making it impossible for the uterus to build an adequately thickened lining to support the implanting pregnancy's root system subsequently, in a later attempt at conception. In some cases, an infection occurs in the uterus in such situations called an anaerobic infection or endometritis, where the walls of the uterus fuse together with scarring or adhesions, which we call bands of tissue which straddle the two walls of the inner surface of the uterus. We call them synetia. And these adhesions are a manifestation of a rather advanced endometritis with severe damage to the very root system of the embryos, very root system of the uterine lining, causing permanent damage often. And such women will find great difficulty in conceiving. In the future, they will experience reduced menstrual flow, and even the menstruation can disappear completely. We call that amenorrhea. The condition of fusion of the walls or the presence of adhesions causing these problems is known as Asherman syndrome, a rather grave situation for women still hoping to have children. Simply separating the adhesions surgically will not cure the damage already done to the inner lining, the endometrium, and while it may render the uterus smooth inside, does not provide an adequate endometrial base for subsequent implantation. And miscarriages can also be sporadic, or spontaneous. That means they occur sporadically in either one woman, she'll have a miscarriage, and then she'll perhaps have a pregnancy, and then miscarry again. Sporadic miscarriages are by far the most common forms of miscarriage that we see in the United States. So it can be sporadic, or it can be recurrent when 2 or more miscarriages occur in a row. We call that a recurrent miscarriage or recurrent pregnancy loss. The two must be differentiated because the causes and the treatment will differ substantially in the two cases, sporadic versus recurrent pregnancy loss. There's another form of miscarriage called a missed miscarriage. Used to be referred to as a missed abortion. We don't usually use the term abortion unless the pregnancy loss was induced purposefully. But a missed miscarriage means the pregnancy is lost in the uterus, but it's not expelled. It remains retained within the uterus. The cervix is still closed, and the fetus has passed away. In such cases, it's important to empty the uterus because, as I told you earlier, dead tissue serves as a growth medium for bacteria, usually anaerobic. Those are bacteria that cannot grow in the presence, multiply in the presence of oxygen, that require dead or necrotic tissue to grow in. And all women have got anaerobic bacteria in the vaginas, making them susceptible to the infection that I described earlier, which can progress, damage the uterine lining either partially or completely, and lead to repeated miscarriages in the future or even infertility. The one that can manifest as Asherman syndrome. Now, as I mentioned earlier, about 1 out of every 5 pregnancies, 20% are lost in miscarriage. But the older the woman becomes, the higher the incidence. Let me give you an example. In a woman under the age of 30, the risk of miscarriage is only about 10%. Whereas when a woman reaches 45 years of age, it can be as high as 60%, and in women in their mid-40s as high as 45%. And this is largely due to the fact that most miscarriages, almost 80% of them, are due to abnormalities of the embryo. And nature, in its magnificence, if there's an abnormality of the embryo, will usually not allow the pregnancy to continue and will empty the uterus through miscarriage spontaneously. So there's no doubt that the commonest cause of miscarriage is abnormalities of the embryo, either structurally, genetically, or chromosomally, and much more commonly the latter. Chromosomal abnormalities are very, very common in eggs, and as I've told you on numerous occasions, it's the egg rather than the sperm, although the sperm can do it as well, that causes an abnormality in the embryo that we refer to as aneuploidy, an irregular chromosomal numerical component. And such embryos will either not attach, or they'll attach and be lost as an early pregnancy loss, or if you're very unfortunate, it'll continue on and produce a birth defect. We're here referring to miscarriage, so again, chromosomal irregularities of the egg transmitted to the embryo is by far the commonest cause of miscarriage, in the first trimester especially. Now, it's very interesting to note that the further a woman gets along in a pregnancy, the less likely it is to miscarry. Miscarriages that occur, miscarriages are far more common when in the early stages. it's very important to know that about 60% of all embryos that reach the uterus overall are abnormal chromosomally and are doomed. But miscarriages that occur beyond the early stages of pregnancy are far less frequent. In fact, if a woman gets beyond the 12th week of pregnancy, the risk of miscarriage is under 5%. If she gets to the point of the pregnancy being visible by ultrasound and confirmed as viable by ultrasound, the risk of miscarriage is well under 10%. When she gets closer to the middle of pregnancy, around the late mid-trimester, around 15, 16 weeks, the risk of miscarriage is under 2%. So it's important to understand that the further the pregnancy gets along, the less likely it is to miscarry. And that's why a wait-and-see approach in the management of miscarriage is so important. If we see a woman bleeding and she can hold out and get beyond the first trimester, it's far more likely she'll keep the pregnancy. Now, how does miscarriage present itself? By the way, one last thing. The causes of miscarriage, as I mentioned, are usually due to the embryo being abnormal, usually chromosomal rather than genetic. But there are also toxic medications and exposures that can increase the risk of miscarriage. Infections, severe infections that result from viral infections or bacterial infections, especially if they're associated with a high fever, increase the risk of miscarriage. And if there are anatomical abnormalities in the uterus, such as a woman being born with a separation in the middle of the uterus known as a septum, there's an increased risk of miscarriage. But in such cases, when there is an anatomical abnormality of the uterine structure, the miscarriages usually occur in the mid-trimester, after the 12th week. Similarly, mid-trimester miscarriages are very often due to weakness of the neck of the uterus or the cervix. The cervix is like a bottleneck, opening up into the bottle, opening up into the uterine cavity. And there's a little sphincter or valve that holds the cervix tightly closed where it opens up into the uterine cavity. This can be congenitally defective, or it can be defective due to previous surgery or childbirth. And when that happens, you can develop a condition called cervical incompetence. Here the pregnancies last very rapidly. The woman may first notice some bleeding, hardly any pain, and the pregnancy starts being expelled, and then by the time you get to identify that it's happening, you can see it's too late. Treatment of this condition is largely prevention. If there's a history of this having occurred before, an ultrasound examination confirms that there's a weakness in the neck of the cervix, you can put a stitch around the neck like a lasso and tighten it and do it surgically, either through the abdominal route, but usually vaginally, by putting a cervical cerclage or stitch around the cervix, which will hold it closed and prevent this from occurring in many cases in the mid-trimester. This form of mid-trimester miscarriage is very often recurrent, and the woman will present with history of repeatedly losing pregnancies after the 12th week, usually painless and very rapid. So how does a miscarriage present? How does a woman know she's at risk? Well, obviously bleeding occurs. While the bleeding is painless, this is usually only a threatened miscarriage, suggesting that it might correct itself spontaneously over time. And so the treatment is bed rest and a wait-and-see approach. In some cases, if the woman has a low blood progesterone level, you can add progesterone, which will relax the uterine muscle and prevent it from contracting. But the very first thing to do is to confirm that the pregnancy is viable, and this requires an ultrasound. In some such cases, you'll see a clot of blood, a dark area developing just at the outside of the developing conceptus. We call that a retrochorionic bleed, a retrochorionic hemorrhage. This little area of separation of the placenta, if you take a wait-and-see approach, well, the bleeding will stop, and the woman will, and the pregnancy will be rescued. But in some cases, it'll expand, and the entire pregnancy will come away becoming an inevitable miscarriage. So it's important first to check and see that the uterus itself, that it's really only a small area of bleeding behind the placenta, to measure it and to watch the woman on a regular basis, confine her to bed rest and sedation, and then take a wait-and-see approach. Sometimes adding progesterone, and if for any reason she's on blood thinners, to stop those blood thinners while she's recuperating. This so-called retrochorionic bleed or subchorionic bleed often presents with bleeding that is painless, and it's often a brown blood. It's important to know that if the woman's bleeding and the blood is dark or brown, it usually means it's old blood, it's not a fresh bleed, which is better for you than to have red blood and clots. And of course, the heavier the bleeding, the more likely it is to become an inevitable miscarriage, especially if the woman's having cramping along with bleeding and along with that clots. So the important point here is that when you see a woman presenting with bleeding, the first thing you've got to know is this a woman threatening to miscarry? So you examine the woman and insert a speculum into the vagina, look at the cervix. Sometimes bleeding is coming from the outer surface of the cervix because of an erosion, an eversion, irritation on the cervix, often due to infection called cervicitis. This type of bleeding is not a threat to the baby, and ultrasound will show no bleeding in the uterus and a healthy, viable pregnancy still being sustained. But if the bleeding is issuing through the cervical canal, that's when the risk of a threatened miscarriage is really important. And those are the ones you've got to be very watchful of. So what happens with IVF? There appears to be a slightly increased risk of miscarriage after IVF. Not much, but slightly. Interestingly and paradoxically, that risk decreases substantially if the embryos that were transferred to the uterus were deemed to be chromosomally normal. If they are chromosomally normal, then the miscarriage rate is about a third of what it would ordinarily be in the absence, as compared to cases where you've put back embryos that were not tested by PGS or PGT and found to be normal. So now let's move on to the treatment. Obviously, if it's a missed abortion, you've got to evacuate the uterus either medically or surgically. Medically, we use a drug called misoprostol, which works pretty well and will evacuate the uterus within some time, a couple of days at most, after taking the medication using a strict regime. After the woman has passed the fetus, you always do an ultrasound to make sure that the cavity is completely empty, because if it's not, you've got to evacuate it by D&C or dilatation and aspiration or evacuation. D&C or D&E. You cannot leave products of conception behind because of the risk of endometritis and damage to the uterine lining, as I mentioned earlier on. So you can do it with misoprostol, but most people, including myself, prefer to empty the uterus surgically, doing a D&C or a D&E as soon as I recognize that there's a missed abortion. If the woman has already had an abortion, the importance then is, and it's not missed or missed miscarriage or a miscarriage itself, it's very important if it wasn't, if there is a passage of products, to confirm that the uterine cavity is empty. This again requires an ultrasound. If it's not empty, you've got to evacuate the uterine cavity. And the third issue to consider is if the woman is completely aborted, of course you don't need to do an evacuation of the uterus, and that you will only diagnose by doing an ultrasound. If the woman becomes infected with endometritis, it can lead to subsequent infertility because the lining is permanently thinned and damaged, even if you try to repair it by breaking up adhesions, doing what we call a hysteroscopy, where you look inside the uterus, visualize the adhesions, and then transect them visually. That may restore the regularity of the cavity, but it does not necessarily solve the problem, because the lining may have been damaged. Only way to know if the lining is damaged is to follow up, and when the woman ovulates in her next spontaneous cycle, or if you're doing hormonal stimulation, you do an ultrasound at the peak of estrogen effect, which is at ovulation, or just prior to triggering the woman with HCG, and you measure the thickness of the lining. It should measure more than 8 millimeters. If it's less than 8, that means that uterine lining has been damaged, maybe permanently. If it's 8 to 9 millimeters, it's in the transitional or intermediate zone, and if it's more than 9 millimeters, it's usually fine. There's no such thing as a lining that's too thick unless it's caused by pathology, such as hyperplasia or cancer. So those are the things that we need to be aware of in terms of damage to the uterus and the way we treat it. Sometimes the infection spreads into the fallopian tubes, causing generalized pelvic infection as the pus spills out of the ends of the tubes, causing pelvic peritonitis, and that requires medical and often in-hospital therapy, but certainly intravenous antibiotics. And sometimes, if there's an abscess that develops in the pelvis, it needs to be drained, and on rare cases, it even requires removal of the tube and or the ovary, or both. So if there's an abscess or pelvic inflammatory disease due to the infection spreading through the tubes, then you have to deal with it radically, aggressively, to prevent serious risk to the woman. If there is infection that doesn't reach the tubes, it can still block the tubes as they leave the uterine cavity. We call that uterocornual adhesions now in that case. The tube, the rest of the tube is not affected, it's just fused through scar tissue forming as it leaves the uterine cavity. This type of damage to the uterus is also usually permanent. We used to do surgeries where we went in and cut out that section of the wall of the uterus and reimplanted the tube into the uterine cavity, but it was usually dismally a failure. And today, the treatment when the tube is damaged or blocked is IVF. In some cases, the infection remains confined in the uterus, causing severe pelvic or pus collection inside the uterus. And that is called a pyometra. It's very rare unless there's a malignancy in the uterus involving the uterine cavity or the cervix for pyometra to develop, but it can do, and I've seen it happen in the past. Now we turn to another issue, and that is if a woman has a miscarriage, it's very important to test her blood to make sure to see whether she's Rh negative or positive. If she's Rh negative and the husband is Rh positive, she needs to receive RhoGAM. Otherwise, there's incompatibility for the fetus and future pregnancies can be lost. So it's very important, if there's any bleeding, if it occurs after the missed period, to treat with RhoGAM to avoid the woman developing antibodies to the Rh factor, which can damage any baby that develops in the uterus subsequently. So RhoGAM must be given to all women who are Rh negative who miscarry after the 4th or 5th week of pregnancy. Now let's turn to the last group, and that's called recurrent miscarriage. This is very important. I've spoken about this before, and I'm not going to go into detail here. You can look at one of my other blogs or another video on recurrent pregnancy loss for more information. But recurrent pregnancy loss occurs when there's 2 or more miscarriages in a row. And you remember I told you that 80% of miscarriages that occur sporadically, if you look at all the miscarriages that occur throughout the country, 80% are due to the embryo being abnormal, usually chromosomally abnormal, but it may be genetically abnormal as well. It can occur from other causes as well, but sporadic miscarriages are usually due to the embryo being abnormal in 80% of cases. Only in 20% of cases will a sporadic miscarriage be due to a failure for the embryo to attach, implantation. In other words, a uterine factor. It's usually an embryo factor. But when a woman miscarries repeatedly, it's far less likely to be something to do with the embryo being abnormal. In such cases, the commonest cause is an implantation dysfunction. It's no different than a seed-soil relationship. When you plant a seed in a garden, in the soil, in order for it to grow into a healthy plant, it has to be a healthy seed, and there the analogy is the embryo. We've spoken about that. And the other thing is that the soil, in this case the uterine lining, needs to be receptive. You can't put a good seed in a bad soil or a bad seed in a good soil. The commonest cause of repeated miscarriages is not the embryo being abnormal, unless it's due to a rare condition called an unbalanced translocation, which we diagnose by testing the woman and the man to see the chromosomal makeup in their bloods. And treatment involves IVF and embryo selection through PGS or PGT, and then transfer of a healthy embryo to the uterus, not one with chromosomal unbalanced chromosomes. So the commonest in almost all cases, 80% of cases, repeated miscarriages are due to an implantation problem involving lack of receptivity of the uterine lining. And here the treatment depends on the cause. There are many causes, but about 90% of all of the causes relate to 3 important factors. 1, the thickness of the uterine lining, and we spoke about this earlier on. The second is the regularity of the uterine cavity inside. It's got to be smooth. There can be polyps or fibroid tumors growing into the inner wall of the uterus, or scarring, which has damaged the uterine regularity. And in such cases, the pregnancy will be rejected because of the foreign body reaction, where the body sends immune cells to the uterine cavity and expels the embryo. The third case occurs, as I mentioned earlier, where the lining is too thin. If the lining is under 8 millimeters in thickness repeatedly, then you have the risk of repeated miscarriage or infertility. And the repeated miscarriages can only, in that case, be dealt with if you restore the lining to an adequate thickness. This can be done by improving the blood flow to the uterus through the administration of vaginal Viagra, which I was the first to introduce about 20 years ago, or the administration of estrogen, and also using antiprostaglandins such as aspirin or indomethacin. These drugs will help relax the uterus even more. But the Viagra improves the blood flow through the blood vessels that pass through the wall of the uterus to reach the lining, carrying more estrogen into the uterus. And I've given a couple of video live feeds on these issues which you can read up. The third one happens to be immunologic. And proudly, we were the first people to really introduce the treatment of recurrent IVF failures or recurrent miscarriages that are due to an immunologic cause, with IVIG at first, intravenous gamma globulin, and more recently with a much less potent and far more innocuous and inexpensive substance called intralipid. Again, there's a lot on other live feeds on this subject. In such cases, when you test a woman's blood, you'll find her to have activated uterine natural killer cells. Natural killer cells are immune cells that frequent the uterine lining and that are responsible for regulating implantation. When they become activated, they overproduce a substance called Th1 cytokines, predominantly interferon gamma or TNF alpha, but others as well. And treatment requires negating the effects of these excessive cytokine, Th1 cytokines, through the infusion of gamma globulin or intralipid. Again, there are other blogs and video live feeds that discuss this in greater detail. Please look for these on this website. You can also diagnose this by doing an endometrial biopsy and measuring the cytokines in the endometrial tissue. More recently, blood cytokine measurements have been used. They are helpful, but they're not nearly as reliable. The blood test that I mentioned to you right at the beginning, which is called the K562 target cell test, is the best way to diagnose activation of natural killer cells. And treatment is, as I've mentioned, the use of intralipid and steroids, dexamethasone or prednisone, or IVIG in combination with steroids. In some cases, there are antiphospholipid antibodies that are also in excess. They can also attack the roots of the embryo and damage it. Treatment there is the use of Lovenox or Clexane, which are heparin-like substances that prevent these antibodies to phospholipids from attaching to the surface of the roots of the embryo and protect the embryo in this way. We see it commonly in women who've got endometriosis or women that have got autoimmune diseases such as lupus erythematosus, rheumatoid arthritis, and hypothyroidism. All this is spoken about in greater detail elsewhere on this website in my video live feeds. So today we've discussed miscarriages and how they impact also in the IVF scenario. We do IVF when there is a recurrent miscarriage, when there is a problem with recurrent miscarriages due to immunologic causes. We also do it when there's been damage to the tubes due to infection resulting from a previous miscarriage. We may have to do it in other cases of sporadic pregnancy loss when there is damage done, severe damage done to the uterine lining. So this is the background. One last thing, whenever a woman bleeds, are following on a pregnancy being initiated, always also consider the possibility of this being a tubal or ectopic pregnancy. It's got to be looked for because it's a life-endangering condition, and I will do a live feed at a future date on ectopic pregnancy per se. But if the bleeding occurs and there's sudden onset of pain, lightheadedness, fainting, it could be an ectopic. Sometimes you can pick an ectopic up before it even ruptures and causes this severe hemorrhage into the uterus that produces the collapse. And the way you pick that up is by doing early ultrasounds. And if the ultrasound after 6 weeks along shows nothing in the uterus but the blood pregnancy levels are continuing to rise, then even if you don't see the ectopic in the tube, you've got to consider ectopic pregnancy as a problem. And as I said, we'll discuss this at a later date. Thank you all for your attention, but before I leave you, I just want you to know that if any of you are interested in talking to me, all you need to do is call my lovely assistant, Patty. Her number is 702-533-2691, and set up an online consultation with me. Patty will forward you a questionnaire to complete, which you need to do as diligently as possible and return to her quickly, and she will then set you up with a consultation online via Skype, FaceTime, or Zoom with me. You can also reach Paddy if you live in the continental United States and Canada. You can dial 800-780-7437. That's a free call, and you can reach her for the same purpose. Alternatively, you can go to my website, sherivf.com, SHERIVF.com. When you get there, you'll find a form that you fill in as an invitation to do a consultation. Click on that. It'll take you to a page where you can fill in a form and send that form off to Paddy by just clicking on the submit button. And when Paddy gets that, she will reach out to you. Make sure to leave your cell phone number there, or the easiest phone number that reaches you, and she will get to you and help you in terms of getting that form completed. Finally, if you wish, you can email Paddy directly for more information at concierge, CONCIERGE, at sherivf.com for further information. Thank you so much and have a wonderful day.